Hello, and welcome to the sixth webinar for Willows Health Leicester. So far, we had a very successful webinars which were chaired by Dr. Kapasi, and the last of which was on Leicester lockdown with Professor Ivan Brown, Director of Public Health. You can catch on all our webinars on Willows Health website, Willows Health YouTube channel, Facebook, Twitter, and Instagram. I will be chairing this webinar as the Educational Director of Willows Health and also as a national trainer for minor surgery. I'm very pleased to be joined by an inspiring audience, not only from Leicester, but the rest of the UK, and as far as the Middle East, India, and other countries. We have listeners who are medical doctors, surgeons, nurses, physiotherapists, podiatrists, physician associates, students, and many more. Today, we are delighted to have Mr. Maneesh Bhatia with us. Mr. Bhatia is an orthopedic consultant at University Hospitals of Leicester since 2009. He did his fellowship in foot and ankle surgery at Cambridge and was awarded the Nuffield Doctor of the Year in 2019. He was a previous head of service for elective orthopedics at UHL and leads the UHL Senate and governance. He is also an FRCS examiner and been an advisor to NICE and to NIHR, which is the National Institute of Health Research, and various other educational bodies. The list is endless, but I would like to especially mention his two books, which I have personally read, and the first one of which is an orthopedic guide for today's GP. It is a very comprehensive, thin book, which contains both acute and chronic problems in clear sections. It has the diagnosis, investigations, and management. And the other latest book which he has published, which again I use, is the musculoskeletal injections and options, which includes things about physiotherapy, exercises, and various techniques of joint injections along with their risks and complications. And so without any delay, I give you Mr. Maneesh Bhatia.
Thank you very much, Fahad. That's very generous of you. I am humbled to be on today with you, and I'll do my best to share what little I know. Hopefully, our audience will be benefited by talking about foot and ankle problems. So thank you once again.
So, Mr. Bhatia, obviously you have lots of experience in foot and ankle, and the first time I heard of you was an interesting story, and I want to describe it as well. So my wife is a consultant anesthetist at UHL, and she once informed me that people were looking for Mr. Bhatia, and I was like, oh, what happened? And she goes, there was a Leicester City football player who injured his ankle, and they were looking for him in the hospital, trying to find him where he is. So I don't know when that happened. It was many, many years ago. But that's my first experience of hearing about you as a foot and ankle surgeon involved in the Leicester City Football Club. So I hope you keep up the good work. And so the first question today for you is that most GPs or primary care physicians find it quite challenging to examine foot and ankle. And because obviously it's that part of the body which we not really hone on into our education and stuff, but we focus more on shoulders and hips and knees. But foot and ankle is a very important factor, obviously, which plays around with our running, walking, and daily activities. So do you have any tips of how shall we approach somebody who presents to a clinician with a foot and ankle pain, for example?
Yes, so Fahad, as you said, that foot and ankle is, I wouldn't say neglected, but obviously it is much more complex because there are multiple joints, tendons, ligaments, lots of structures, and therefore it can be difficult. What I will try to do is I'll try to simplify it as much as I can, and I'll try to give certain tips from my experience which I have found useful. About talking to patients and what are the important pointers about certain conditions. And this becomes especially more relevant in today's age. We are all now living in it's not normal now. We're adapting to this new normal. So history has become so important because remote examination, telephone, video, that's the way it is. So talking about history, it's always been said from medical school that history is the most important thing. Listen to the patient. Talking about foot and ankle. So let's try to break it up into different parts. So forefoot, midfoot, and hindfoot. So forefoot, not sure whether you can see, but this is the part of the forefoot where the metatarsals heads are, and then around the midway level, that's the midfoot, and then obviously here is the ankle. So what can go wrong in forefoot? Big toe. Now, big toe, essentially there are two main problems with big toe. The first one is bunion, and history I don't think is very much important in bunion. Bunion, people know what it is. It's a bony swelling on the side and the toe starts drifting outwards. The main issue with big toe is pain. And when somebody talks about pain and swelling, then one must try to keep arthritis of the big toe at the back of the mind. And the thing about arthritis, it can be either mild, moderate, severe. So in mild arthritis, the pain is intermittent, whereas as the arthritis becomes severe, the pain becomes more constant, and then the toe becomes quite stiff as well. In addition to that, what happens in moderate to severe arthritis is there is a bump on the top of the joint. So the bump on the top is joint somewhere there. This is often called by patients as bunion, but in truth, it is actually overgrowth of the bone due to osteophytes. And one question which can help is asking the patient, can you go on your tiptoe? Does it hurt when you go on your tiptoe? And the answer is often yes. And that's because of the fact that the dorsiflexion of the big toe is limited because of the bone growth. Okay. And obviously, once you think about arthritis, you will get the x-rays done. So moving to the inside of the foot then, forefoot. One of the most common cause of pain in the forefoot is Morton's neuroma. Now, Morton's neuroma is relatively easy to diagnose just by history. And the important things which you can ask about the patient is location of the pain. Usually the pain is plantar. How does it feel like? The patient often says that it feels like walking on a pebble. Does it hurt in certain shoes? The answer is yes, it hurts in tight shoes. Can you walk barefoot? Usually people say, when I walk barefoot, the pain becomes worse. Does it hurt in night or at rest? The answer is often no. Does the pain travel to the toes, or the pain, is it in the tips of the toes? The answer is often yes. And then not always, but sometimes patient says that the toes feel numb, a bit numb or altered sensation. And that's the giveaway. If somebody says that, then it is Morton's neuroma. Now, one important differential diagnosis of Morton's neuroma in forefoot pain is from something which we should not miss. And when somebody says that, oh, doctor, I have developed acute pain and swelling in my foot last week and it's not getting better and the foot is very swollen, or they say 2 weeks or 3 weeks. When the once swelling comes, swelling is a feature of stress fractures or stress response to the bone, and that's common. Sometimes that can happen in metatarsals, and that's a very important differential diagnosis. When somebody mentions a lot of swelling, then one should think about either a stress fracture or a stress response and need to obviously consider X-ray or MRI scan accordingly. I think rest of the things are trickier to explain and they're better done on examination. So the other differential diagnosis of forefoot pain could be synovitis of the second MTP joint. And we can talk about examination and I'll explain how to differentiate the two. But just talking about history alone, then patient often describe, if they describe pain in the midfoot. So midfoot, they won't say, but they will say, oh, the pain is on the top of my foot. So usually somewhere around that region, they will say midfoot region or this region. And the pain becomes worse when they tie the shoelaces too tight. And this is a pointer for arthritis of the midfoot, and the commonest is arthritis of the TMT joint, tarsometatarsal joint. And that usually affects people who are relatively older, so maybe in their 50s, 60s, 70s. But it is a common arthritis of the tarsometatarsal joint is the second most common location after the big toe. Then we move towards the ankle. Now, ankle, location of the pain is so important. Okay? If somebody says, I have developed pain and swelling in my ankle, and if you ask, where is it exactly? And if they're pointing behind the medial malleolus, so the medial malleolus, that region, then posterior to medial malleolus, the most important cause of that pain is tibialis posterior problem. Okay, so it appears initially with acute pain and swelling, and then gradually the foot becomes flat and the foot turns outwards, or valgus deformity, and that's typical of pathological flat foot, and the commonest cause is tibialis posterior dysfunction. If the patient describes pain in the front of the ankle, then you're dealing with arthritis of the ankle joint, by and large. And then we can go on and on about, but one important message I would like to give, which is Achilles rupture. And I think I'm passionate for it because I've seen lots of cases being missed. And the problem is the patient often doesn't know that they've ruptured the Achilles. Okay, so they were involved. For example, I'll give you an example. There was a chap, 75 or 76 years old. He was playing football, yeah, and he fell down, and he got up, he limped, went back home, phoned his GP. Oh, doctor, I've sprained my ankle. Doctor says, take anti-inflammatory. But the problem here is that if somebody says that they've sprained the ankle, the question is, how did it feel? And the answer is, it felt like somebody had kicked me in the calf. If they say this, then it is Achilles rupture until and unless proved otherwise. Is it painful or not? Achilles ruptures usually are not painful. What is the main problem? Well, I'll find walking difficult. It's my leg is weak. Those are the things when one thinks about Achilles rupture. So I hope, Fahad, that I've given some pointers for some important conditions which can be helpful for people who are listening.
Thank you, Mr. Bhatia. I think that was a wonderful explanation of the history taking for foot and ankle problems. Now, just to advise the listeners that we have an open Q&A session on running, which Dr. Kapasi is kindly moderating. So if you have any questions, comments, please write them down on the Q&A tab, and we'll pick it up from there. Secondly, we have some videos for examination, which are on a link on the Q&A section. These are a 14-minute YouTube clip for examination of various foot and ankle problems, which is very, very helpful because you had a look through them. We thought playing it now would take too much time, so we'll focus more on the practical issues rather than going on YouTube at the moment. Mr. Bhatia, I have a couple of questions from your history taking just now. Now, as you said, we can get bunions on the foot, which is a very common problem. And we have loads of patients coming into primary care or and complaining about bunion that they have pain. Is there something which they can do to prevent the progression of the bunion? And secondly, at what stage do you think we should refer them to a podiatrist or for surgery? And the second question was about Morton's neuroma. So what treatment options can we offer patients and how do we diagnose them apart from examination? Thank you.
So I'll take one by one. So let's talk about bunion. That's a very, very common problem, as we all know. Now, bunion, why do the bunion form and how do they progress? So bunions are inherent. So most of the patients who have bunion, it runs in the family, and it's usually the mother's side to be blamed. Okay, so 90% is genetic transmission, but there are certain things which can make the bunion progress faster. And the first thing is the shoe wear. So what you're wearing is really important. If you have got a maternal history and you have a small bunion, and if you start wearing very high heel shoes with narrow toe box, then the progression will be fast. The second important thing which can cause progression of the bunion deformity is flat foot. So normally flat foot, it can be mostly physiological problem, but obviously, as I was speaking earlier, it is pathological when one of the tendons, the tibialis posterior tendon, doesn't work very well. And in those particular cases, if you have bunion and you have flat foot, then the bunion chances of bunion progressing is higher. So what can you do to prevent it? Sadly, there is not a lot. What all you can do is obviously asking your patient to wear sensible shoes. So no heel, or if they have to wear heel, then it's better not a pointed heel, but sort of a gradual, platform sort of thing. They need to buy wide toe box shoes. So fashionable shoes, unfortunately, are not very good. Can they use orthotics? There are different types things available in the market, like bunion guard and things. I'm not a big fan because patients don't tolerate them very well. So there is not a lot a patient can do other than blaming their mom if they've got it from the mom, or blaming high heels. So hope that gives you the answer. And if certain things, when to operate, when not to operate, if we have time and if you want, we can discuss about that. I'll now come back to your second which is how to treat Morton's neuroma. Fortunately, I have suffered from 2 foot and ankle problems, and one of them is Morton's neuroma, and the other one is plantar fasciitis. And I say fortunately because it gives you an insight into what patients really. So Morton's neuroma, in my experience, can be really when it flares up, it can be really painful. And how I have managed, so I used to play tennis, I used to run. When it flares up, I give up those activities. There are certain types of shoes I know if I wear, they will bring the pain. So I avoid using those shoes and I go for most comfortable shoes, which are wide. I do take anti-inflammatory, and I take a course of anti-inflammatory for about 2 or 3 times. And I also rub a topical gel. And usually these measures help to calm it down. And I haven't had so far, because I know what it's Morton's neuroma when it comes, and I keep it at the bay. And the key here is that if you pick up a Morton's neuroma early and do remedial measures, what I've described, you probably won't need to go further, step up the ladder. So for example, if these measures have not helped, then what to do? I think the next step then is to consider a steroid injection. I'm a big fan of Morton's neuroma steroid injection because the results of surgery are not 100% predictable. And we have done lots of studies, and we have seen that surprisingly, in Morton's neuroma, the effect of one single steroid injection can last for up to 5 years. We are going to publish it soon in 50% of patients. And if the patient has received 2 steroid injections, then the chances of improvement are even better. So steroid injection is a very good treatment for Morton's neuroma, and it should be tried as the first invasive intervention. Unfortunately, if the steroid injection hasn't helped or the pain has come back after 1 or 2 injections, then I think surgery is the way to go. And then that's what I would consider.
Thank you, Mr. Bhatia. I think that answers the question about bunions, is that there's nothing much we can do if once they have developed and starting to develop, apart from wearing good shoes, soft padded shoes, and wait and be referred for surgery if it's causing a lot of problem. Morton's neuroma, again, we have seen them lots in our clinics as well. I do injections as well, and they are very successful, as you have said. And if they don't work, then they're referred for a surgical excision of the neuroma. Mr. Bhatia, now during these COVID times, you said it's a new normal, and people have been advised by the government to take up exercises in the form of running and cycling. And every day we see loads of people going around cycling and running. And also the impact is that we see lots of foot and ankle injuries happening as well. So are there any particular issues which can arise from a lot of running, which can happen, and how will we deal with that, please?
Yes, I think you're absolutely right. People are on their feet now, aren't they? And when they are on their feet, then obviously feet complain. uh, yes, we have seen an increase in some conditions. And I was in clinic yesterday, and I had, out of 10 patients, I had 2 patients who had plantar fasciitis. And one of them had plantar fasciitis on one side for about 8 months. And the other side started just after the lockdown, so starting about March time. And the second patient had again, heel pain going for about last 3 months or so, and both of them confessed that they have started. One of them started running, the other one started playing tennis. So it's important and it's good to keep fit and whatever you can do, but it can, especially if you've started suddenly something which you're not used to, then you can see issues such as Morton's neuroma or plantar fasciitis. So these issues can occur.
Thank you. So, and do you have any slides or any ways you can show what happens in pathophysiology-wise in plantar fasciitis and what treatments are available to make it better?
Sure. I think we can ask Kavita to put up our presentation so we can go. I can talk about it. It will be easier. So plantar fasciitis, if you can, the same presentation, I think. That's it. So yeah. So talking about plantar fasciitis. Now, as you can see, the photograph shows what plantar fascia is. So let's understand what is plantar fascia. So it's a band of fibrous tissue which connects the calcaneum or the heel bone to the toes. Okay, and this band has, or this thick band of fibrous tissue has got 3 divisions or 3 discrete. And as we can see on our image, we have a medial and central band and lateral band. And the red area which see in which is pointed with the blue arrow is the area where patients often get pain, and that's the area where people get plantar fasciitis. So, as we said, it's a fibrous structure, and when we stand on it, we put a lot of pressure on this fibrous. And what happens is, because of that load, increased load, now that load could be due to standing, could be due to running, or could be due to being overweight. Sooner or later, what happens is, because of the increased pressure, there are micro tears, because the elasticity is not very good. So, there are micro tears, small tears. And when these small tears occur, then they inflict an inflammatory response, and that's where the pain starts. So that's the pathophysiology of plantar fasciitis. Next slide, please. Okay, so the commonest cause of heel pain is plantar fasciitis. And although the literature says the incidence to be about 10%, I say, based on my experience as well, that there are 2 types of people in this world. First group is the one who has had plantar fasciitis, and the second group is of that who haven't had it yet, but it's going to happen to them sooner or later. So it's very common. It happens. And it's a condition which is relatively very easy to diagnose. So first step pain. What do we mean by first step pain? So when it starts, the presentation is that when the patient wakes up in the morning, then they can't put their heel down due to pain. Or if they're sitting down and they start walking, then suddenly first 5-10 minutes, it's very painful, and then it settles. Gradually, however, it becomes more insidious, it becomes more chronic, and the pain can be there, dull ache all the time, and then it can be aggravated by standing for too long or doing too much towards the end of the day. As we discussed, the predisposing factors, obesity, standing for a long time. So in the past, plantar fasciitis used to be called as policeman's heel, and that was because policemen were standing for a long time on their feet. Running, as we said, it can happen. And one very important predisposing factor is tightness of the posterior chain of muscles. So all the muscles, hamstrings, gastrocnemius, soleus, if they've got tightness, then they put a lot of pressure on plantar fascia, and that can increase the pain in plantar fasciitis. Now, the slide with the photograph is, in my experience, that's where the tenderness is. So if the patient describes these features, and if you put your thumb or index finger in that area, which is medial or medial band or medial and central band, the tenderness there usually, that means plantar fasciitis. Next slide, please. So we talk about the treatment ladder, and that is how I like to treat plantar fasciitis. So important is to stretch the tight muscles, the hamstrings, the gastrosoleus complex, religiously, regularly for at least 3 months. And I ask my patients to do it 3 times a day. In addition to the exercises, it's always a good idea to use other things such as a firm heel support, not a soft one, the firm one. I'll show you an example. And also the use of night splint. So we'll talk about that in a second. And if these measures don't work, then after 3 months, my advice would be to try shockwave therapy. If shockwave therapy doesn't work, then you can try 1 shot of steroid injection. The problem with steroid is recurrence. However, if you tried shockwave therapy first and then try steroid injection, somehow the effect is much longer. And if these measures don't work, then I think we are talking about surgery. So we'll now go in one by one. Next slide, please. So these are the stretching exercises. So just an example, you can see standing on the step of the staircase, letting the heels free, and then stretching one leg forward, the other one backwards, so that you feel the pressure in the calf muscles. Next slide, please. Now, the one on the left, that I think is very important, the one where the towel roll is being applied. So you can use a band, TheraBand, or a towel roll. But what this exercise does, it stretches all the posterior muscles, including your hamstrings, which are really important. The next one is very easy. If you are just sitting, you stretch your big toe up, and that stretches the medial band of plantar fascia. And the last one on the right is the one where you can roll, like a roller pin, or usually I advise cold water bottle, which is being shown here. Next slide. This is what I was talking about night splint. So night splint, I asked my patient to buy it from Amazon, and it's useful because it stretches your calf muscles in night. And when you wake up first thing in the morning, the pain is not so bad. And this is the example. This is actually the heel support which I have used, and I found it quite useful. So it should be firm, not very soft or silicone gel-like, because it doesn't work then. Next slide, please. And shockwave therapy, I was talking, it's a very safe treatment, and the advantage is that the recurrence rate is very low and there are no side effects. Next slide, please. And this is just an audit which just says that we have seen tremendous improvement. 85% patients improved, and in 75% people said it was 100% or almost 100% better, and side effects were hardly any. And just being shown how a shockwave therapy is applied for plantar fasciitis. Next slide, please. Now, if we have time, we can play. Can we play the video?
Yeah, I think we can.
Yeah, so this is how I perform injection. If there is voice, then I won't speak, or I can speak, whatever. So what I've done here is we marked the area which is most tender by that cross. And before we start the injection, it's important to elicit the tenderness. And the position of patient is also very important. If the knee is bent, that relaxes the muscles, which is in this case, and that faces the heel towards the operator. Now, aseptic precautions are important, and we'll talk about additional precautions later on, what we need to do. And the use of steroids, so one can use, I use depomedron now for soft tissue injections, and I use 1% lignocaine because it's quick acting. And then the preparation here is being done by chlorhexidine. So once we are ready and we know where to go, and just checking again before I go. And these are, and I use a blue needle, 5 cc syringe, and then touch the bone and then withdraw it a little bit. And that is it. Thank you. So that was steroid injection. Now surgery, I won't take much time, but I'll just say that yes, there is light at the end of the tunnel. And previously people used to release the plantar fascia, but these days now we do things differently, which works better. Next slide, please. And this is the operation we do. So the, just there is dimple, the circle is knee, popliteal crease, and that's the transverse cut we make, the black cut. Yeah, that's it. And that exactly. So that is the cut which is made, and then the tight fascia of the gastrocnemius muscle is released. And it's a very quick and easy operation, takes less than 10 minutes to do, and it can work, help improve pain, even for patients who have had plantar fasciitis for about 10, 15 years. Thank you.
Thank you, Mr. Bhatia. Thank you, Mr. Bhatia. I think that was a very good explanation of a very common problem which we all face in our clinics. Now, as you know, the new normal is remote consultations. And as you rightly explained, we can quite easily diagnose these patients remotely as well. So if we find the appropriate place of tenderness, which is just over the heel, and patients can palpate that area and let you know that this is the point where they are most tender. And then you can also give them exercises through NHS websites or through your YouTube or through physiotherapy leaflets, which are available quite freely on various websites. The other problem which we often face and we often struggle to deal with is ankle sprains. People often walk in our clinic hobbling with swollen ankles, and it's a dilemma: X-ray or not to X-ray, whether they want A&E care or can we treat them in the community. So can you talk about various kinds of ankle sprains and how do we diagnose them and deal with them, please?
Sure. So the background is that it's a very common condition and it is related to sporting injuries in 50% cases. In USA, about 3 million people presented to A&E in 4 years. And it's a very common condition. Next slide, please. Can we have the next slide, please? Yeah, and the one after that. Yeah. So we talked about different types of. So very simply, if we classify ankle sprain, you can either based on the location or the severity. So location is either medial or lateral. 85 to 90% of the ankle sprains are lateral. Okay, and then in lateral again, they can be high or low. So high is usually due to injury to syndesmosis, and low ankle sprain, which is the one which you normally see most often, is due to injury to the lateral ligament complex. Medial sprain, on the other hand, are not that commonly seen, and if they are seen, they are usually in combination with ankle fracture or injury to syndesmosis. The second classification is how mild, moderate, severe, type 1, 2, or 3, and I'll talk about that in a minute. Next slide, please. Okay, so this is anatomy, and thanks to footeducation.com, I've taken this slide from them. Hope they don't mind, but it shows anatomy very well. So the ligament on the front, so we're talking about lateral ligament anatomy. So anterior talofibular ligament, ATFL, which is in the front, is the most commonly injured ligament, and it's the weakest of the ligament. The second ligament is calcaneofibular, which is in the middle, and it crosses the subtalar joint. And the third, which is least relevant, is the posterior talofibular ligament. Next slide, please. On the medial side, we have deltoid ligament, which has got superficial and deep parts, and then we have spring ligament. Now, these injuries to these deltoid and spring ligament is relatively uncommon, and I would say that most of the ankle sprains which are seen are due to inversion injury and affecting the lateral side. Next slide, please. However, we talked about the high ankle sprain on the lateral side, and that's due to syndesmotic injury. So these are the 4 ligaments in the syndesmotic complex, and the mechanism of injury is external rotation. So when the foot externally rotate, then one can get the syndesmotic injury. But important thing is that pain is usually not such a big feature, and tenderness is usually above the ankle. So if you keep that in mind, external rotation, higher point of tenderness, and swelling not being very common, then you should think about syndesmotic injury as well. Next slide, please. Okay, so predisposing factors, females are more affected. People who have low BMI, they can be affected more. People who have poor balance or stiffness of the ankle. So those are the predisposition apart from playing sports. Next slide, please. Okay. How to clinically assess. Now, I'll just give you tips here. So severity, we talk, they can be of 3 types. I ask my patient these 3 questions when I see somebody with ankle sprain. Number 1, were you able to weight bear immediately after this injury when your foot twisted in? If the answer is no, I couldn't put weight, then you're talking about a severe ankle sprain. The second is, did you hear a pop? And if the answer is yes, then it's a severe injury. And the third is what you see, or what was it followed by extensive bruising? And that usually means that the ligament is completely ruptured and has bled, and that results in extensive bruising. So if these 3 answers are yes, then you're dealing with a grade 3 injury or complete rupture. In terms of assessment, when they are present acutely a day or 2 after, then I think it's better not to do the test. But after 1 week or so, you can examine and you can see for the point of tenderness, and you can do anterior draw test or tailor tilt test. We don't have much time otherwise, but we can take some time, other time, examination and other things. But these are the important tests. Anterior draw test is the most important for lateral ankle sprain. Next slide, please. Okay, so we covered this 1, 2, 3, 3 being most severe. Next slide, please. So Fahad, you asked about the investigation. So I think if a patient presents to you and you applied the Ottawa rules, so you've looked for, felt for tenderness, or asked the patient in this, where is it hurt? And if there is suspicion of tenderness around the lateral malleolus or 5th metatarsal, these patients need X-ray. Also, if you are suspecting syndesmotic injury, then a weight-bearing X-ray of the ankle is very useful. In most cases, in acute sense, MRI scan is not required. But if this goes on for 3 months or longer, then I would get an MRI scan. Next slide, please. Okay, so treatment now, just to summarize, that the treatment of choice is non-operative, and we do not usually perform surgery for acute ankle sprain, even though they are high. An ankle brace for about 4 to 6 weeks, and you can ask your patient to get it online. I often do that. Followed by physiotherapy, taking anti-inflammatory for first week or so to reduce the swelling, using cold compression. And if you have access, and if you think it's an acute severe sprain, then putting them for a short period in a boot, in an air cast boot, you can refer them to A&E or fracture clinic, or to buying online. That really helps a lot to reduce the swelling and pain initially, and then after that starting physiotherapy. Next slide, please. Okay, so when patient asks how long do you expect, so for most simple grade 1 sprain, 2 weeks, extreme cases 4 weeks. On the other hand, if it is a moderate to severe sprain, then it can take up to 3 months for them to return. Next slide, please. However, in 30 to 40% cases, patients develop pain. And this is the picture you see. It's an arthroscopy picture, and that's all that abnormality, that is all fibrous tissue causing impingement in the ankle joint, that area, exactly. So that causes pain. And if the patient gets pain, then you can try putting a steroid in the anterolateral aspect of the ankle joint, or refer them to be done under ultrasound guidance. And if steroid injection doesn't improve the pain, then they need keyhole surgery for debridement. If patient describes recurrent giving way of the ankle sprain, then I think they should have an MRI scan and they would need surgical treatment for ligament reconstruction. Thank you.
Thank you, Mr. Bhatt. Thank you, Mr. Bhatia. I think that quite clearly classifies different kinds of ankle sprains. And it's good to hear that most injuries can be mild. There may be some severe ones which we can easily diagnose on a proper history taking. For example, hearing a pop, a big bruise, or tenderness over the medial side, which need X-ray and A&E admissions. So I think we can then remotely assess these injuries as well by looking at a video of these ankles during a consultation and see how big the swelling is, if there's any bruising, if they can weight bear, and we can assess them, and then we can also hopefully manage them. And also we have time, so as you said, we can bring these patients back and reassess them after a week and see how they are behaving. If they improve, if they have an improvement, then absolutely it's fine. It might be a small tear, but if they're getting worse, then they need to be seen sooner by a fracture clinic, which can be the same day appointment as well. Now, talking about radiology and X-rays, as you said, may be required in some situations. So with these COVID crises, I know we have hospitals divided into hot sites and non-COVID sites. We have some services running and some not running. Now, as we are aware, you are in chair for Alliance, which is basically which manages the three pillars of LPT, UHL, and LLR PCL, and you head all three of them. So what do you think is happening with these days with radiology? Are we still able to refer patients normally? Is the service running as good as it should be?
Yes, absolutely, Fahad. You can refer, and as you said, Alliance actually in COVID has come out as really important for Leicestershire because Alliance is the cold site, most of the patients. So, as GP, when you request on ICE, you have various options. Where can you send the patient? Obviously, if the patient lives in city, then there are not Alliance hospitals in the city. But if the patient is in Leicestershire and they can approach, then you can send them for an X-ray if you need to Loughborough. They live in Melton, Hinckley, Colville, Market Harborough. So these are even Lutterworth. So these all sites are doing X-rays. If the patients, in fact, need ultrasound scan, so GPs are free to request for ultrasound scan. The only thing I would say here with caution is that if you request directly an ultrasound scan of a shoulder, that will be rejected. The shoulder colleague of mine, they want an X-ray to be done first because it can show a lot of things such as rotator cuff calcification, arthritis. So if you can request an X-ray and ultrasound together, but you can't just request an ultrasound for shoulder. But you can request ultrasound scan otherwise for Achilles tendon, for example, and these can be done in Alliance. The other investigation, MRI scan, that is not in Alliance. So if you are suspecting, issues, you can request MRI scan of a knee, or you can request MRI scan of an ankle. So this is just sort of a brief, very brief, quick outline on the radiological investigations at the moment.
Thank you, Mr. Bhatia. So as GPs, we can still refer patients to UHL, which is the Glenfield site, for an elective X-ray, as we normally do. So they are still up and running as normal. So you should not think that we can't X-ray patients while the COVID is on. So we can still utilize a full service, X-ray at Glenfield. The walk-in centers at Loughborough Urgent Care Center is still open and has an X-ray facility as well. So we can send our patients over there.
Yeah.
The next question, I think we have short of time. I'll run through the last question really, which is a very important one, because we're finding that there is a strong link of steroids and COVID. So people who may get COVID infection may get it worse if they had a steroid injection or a steroid course recently. So how do we mitigate this risk, and what are the current guidelines for people to restart steroid injection in the joints? Because we have loads of patients who are waiting with very severe knee arthritis, shoulder pains, frozen shoulders, and they're being declined injections because of the risk associated. What do you think from your alliance perspective?
Yes, Fahad, you have raised a very important topical point. You're absolutely right. That there is a perceived risk of immunocompromise, and steroid injection can lead to immunocompromise and thereby make a person or patient susceptible for COVID infection. And for this particular reason, all the steroid injections in UK were suspended or put on hold. Now, these guidelines were reviewed, and the new guidelines came out on the 16th of June, and these were supported by 8 organizations, including British Orthopaedic Association, British Society of Radiologists, Pain Physiotherapy Society, and Rheumatology. And just to summarize, the steroid injection can be performed now. So after 16th of June, the steroid injection can be done. However, there are 2 important things. Number one, the patient does not have any additional risk factor. So diabetes or any thing which reduces their immunity or age. So that's one thing. And second thing is that the patient's symptoms are severe. They've tried various things and their pain hasn't improved. And also, if there are a lot of swelling or inflammation, then steroid injection are in particular helpful. But I will say this here, it's very important that the discussion takes place with patient that they might get COVID, and there should be a verbal and written consenting process. Also, the patient should be advised regarding the aftercare and social distancing, obviously not coming into contact with somebody who might have COVID. The other important aspect of using steroid at this stage is minimum dose of steroid should be used if possible. And I will give you depends on the joint, but normally I use 40 milligrams of dapomedron or Kenalog, but I would now recommend, and in COVID times, that to use 20 milligrams of dapomedron or Kenalog only, and to increase the volume with local anesthetic. So this is the current update on steroid injection, which can be done for judiciously selected patients.
Thank you. Thank you, Mr. Bhatia. I think that's a relief to hear that people can restart injections as long as the patients are aware, they are consented, and it's important to know that injections don't cause COVID, but if someone catches COVID, they may get a more severe illness. So that is the message to go out, because patients misunderstand that injection can give them COVID. So that's not the case. And also we need to use the minimal dose possible. And also if we should try all the medical managements prior to embarking upon the injection. I do them in my clinics, and I only prefer doing them into only one joint at one time, because most people will need both knees injecting, but I would prefer to do one, wait for a couple of weeks. That's the time when the steroid effect diminishes and goes away, and immunity gets back to normal again, and we can do the second one after a few weeks' time. So thank you for that. Now, we have a few questions here, and I will just go through them one by one. The first question was about plantar fasciitis. So do anti-inflammatory medications actually impair the healing process? For example, plantar fasciitis, could it be counterproductive?
It depends on which route we are adopting. So if we are looking for acute relief in symptoms, then we are talking about anti-inflammatory and tablets or topical gel or steroid injection. The way it acts, it's a very powerful anti-inflammatory. The advantage of steroid injection or anti-inflammatories is once the patient's pain is under control, then they will be more amenable to exercises. So that's how I would use anti-inflammatories to get the patient's pain under control so that they can do stretching exercises, which is really the key to the treatment. Shockwave therapy, on the other hand, works completely differently. It starts the healing response by causing micro trauma or controlled trauma. So that treatment actually starts inflammation and then triggers the healing response. So there are publications which say that if you are having shockwave therapy, then better not to take anti-inflammatories. I hope this answers the question.
Yeah, and thank you very much. I think that answers that. Obviously, it's a matter of where and at what stage we use anti-inflammatories and at what stage of the disease we use them. The other question was, what's the online website to direct patients for ankle support? Is there any online website for ankle support? Apart from your website, I'm sure.
My website doesn't sell ankle support. I just Amazon or Google them. I actually sit with the patient and I just Google ankle brace. And then there are 16 varieties at least of ankle brace. And it also, important thing is what fits the patient and what patient can tolerate. It is very important. Most of the braces can be worn. You can put shoes on after putting the brace on. And the one which provides most support and patient find comfortable is the figure of 8. So I don't want to name any commercially made braces, but it's a matter of patient looking through those and the one which they think is going to cause least hindrance, but more support and comfort.
Okay, thank you. So a question just arrived which says, is there a document with the review of steroid injection? So yes, there is a document. I think I will ask Kavita to circulate that document. It's a collection of 8 Royal Colleges who have set up these guidelines, which came out a week ago or 10 days ago.
Yeah, 16th of June.
Yeah, so we can publish those guidelines on our webpage, on our website, which is a nice document to refer to. The last question we have here was about, does flat foot predispose to ankle arthritis? And do you recommend exercises to form an arch? So I know that we have the video for examination, which includes the arch and flat foot in there. So yes, the answer is flat foot does predispose to ankle arthritis, but I will ask you, what shall we do to make the arch better?
So Fahad, depends on what type of flat foot we are talking about. So flat foot is of 2 different types. One is physiological and one is pathological. 90% of flat feet are physiological. And as you said, there are ways of examination where you can easily, I mean, the simplest clue is if it is bilateral and symmetrical for anything, it's usually physiological. The pathological is the one which you need to diagnose, that shouldn't be missed, and that can cause problems. And yes, that can cause arthritis of the ankle, arthritis of the talonavicular, arthritis of the subtalar joint, and that stage 4, which is with arthritis. So yes, the answer is pathological flat foot can cause issues in terms of arthritis. Can you reform an arch? Don't think so. But what can you do? Well, flexible flat feet, you can use the one which are flexible. You can use medial arch support. Tibialis posterior tendon strengthening exercises can be useful, but I don't think they can reform the arch. I hope this answers it.
Yep, thank you. I think that answers the question. We don't see any more questions coming through now, and I think I would like to bring the meeting to an end. So thank you, Mr. Bhatia, very much for coming on tonight and spending your time with us. And I'm sure the audience have learned a great deal about ankle injuries, trauma, plantar fasciitis, motor neuroma, and a variety of different things. Now this talk will be available online on our Willows Health website and also our YouTube channels, apart from being on Facebook, Instagram, and Twitter. If you have any questions or any concerns, please feel free to email us. We have some CPT certificates, which you can organize by emailing on our email academy, which is wh.academy@nhs.net. I would also like to thank Kavita and Kiran, who have worked tirelessly behind the scenes, making all the slideshows running and making sure the webinar goes well, and Dr. Kapasi, who has been meticulously seeing all the questions and moderating them as we were speaking. So stay safe, keep healthy, and keep running. Thank you.
Thank you very much. Thank you.